Hey guys, what's up? Welcome back. I am Shiv Virmani, Indian medical student, author of the book Pharmac Easy. And let's see, are we live or not? I think we are live now. Hey guys, what's up? Yeah, we are live again, and as you all know, today we are supposed to start systemic pathology. And in this session, we will be doing blood vessels and lymphatics. So, guys, first of all, welcome to the Unacademy, the top online learning platform. And um, how are you all, guys? I hope you all are fine. Hmm. And yeah, everything is looking fine. Yeah, I hope you all are fine. You all are fighting for your goals, and let us just start. So, guys, Unacademy learning app. You can install this app for free from App Store or Play Store, and you don't have to pay anything. It is not a paid app. It is a free app, right? Um, then after installing, you can access free special classes and a few tests as well. But if you want to enroll into your batch courses, और अगर आपको काफ़ी ज़्यादा बेनिफिट लेना है, then you have to subscribe to the plus course, जहाँ पर you get you get your knowledge, or you are taught by the top level of educators from AIMS, Safdarjung, and all other esteemed universities, and with the experience of many years, right? And plus course pay, you get benefit of, first of all, you can attend live test, um, you can take quizzes, you can enroll yourself into various batch courses or plus courses, right? And you get a structured schedule where you have a deadline, um, जहाँ पर जहाँ पर you can make your strategy according to the top educator or according to your educator, right? And if you are a second or a third year medical student, then I would refer you this iconic subscription. So in this subscription, you get a benefit of whole Unacademy, जो भी you can access whole Unacademy. आप पूरा हर चीज़ का benefit ले सकते हो, प्लस यू गेट एक्सेस टू प्रेप लैडर एज वेल. आप प्रेप लैडर में भी प्री रिकॉर्डेड वीडियो लेक्चर्स, क्यूब बैंक 2.0, रैपिड रिवीजन कोर्स, हैंड रिटन नोट्स, सब चीज़ का एक्सेस कर सकते हो. एंड दस इट इज़ रियली प्रेफरेबल फॉर अ फर्स्ट, सेकेंड एंड थर्ड medical student. Then for Iconic, there are only 4 choices. You can buy it for 12 month, 18 month, 24 month, and 36 month. And if you want to buy, then you can use the code Virmani, VIRMANI, and you will be getting 10% off. And if you want to buy plus course, then you have many choices. You can buy it for 1 month, you can access it for 3 months, 6 month, 12 month, 18 month, 24 month, and 36 month. So initially, if you want to try, then you can just buy it for 1 month, and then you can upgrade as per your need, right? And yes, it is also same. You will be getting 10% off on using the code Virmani. And प्लस एक नई गाइडलाइन आई है. देयर इज़ वन न्यू गाइडलाइन. सो व्हाट इज़ दैट गाइडलाइन? सो as you all know, special classes are free, right? Right from the right from starting of the Unacademy, special classes are free. So now also special classes are free, but if you want to access a special class, then you have to use a code, right? You have to use a code, and code is same. और ये कोड लगाने के बाद you can access special classes, and बाकी it is free, you don't have to pay anything. So welcome to PathoNION, the pathology companion. I am Shiv Virmani, Indian medical student and author of the book Pharmac Easy. So this is the series that we have started, in which we will be completing the pathology, like we have completed pharmacology in the Pharmac Easy series, and the response for the on the Pharmac Easy series. So we have completed almost whole pharmacology, and you guys loved that series. You guys loved the concepts, my notes, and the way of teaching and all, and that's what is the most important thing for me, because acceptance is important, and you guys accepted me, and for that I am really overwhelmed, and I thank you so much for that. And that's why we started a pathology series, PathoNION, and today we are starting systemic pathology, and we'll be doing first topic of the systemic pathology, that is the blood vessels and its disorders, basically. Yeah. And we will be discussing the important carcinoma, that is the most important thing जो पूछी जाती है, right? And in today's we'll be discussing the blood vessel in the ये वाला 12 PM वाले सेशन में we'll be discussing the blood vessels, and जो हमारा 4 PM वाला सेशन होगा उसके अंदर we'll be discussing heart finally, and we will try to complete whole heart in the 4 PM वाला session, but I think it's a bit difficult because heart is very huge topic, and if you want to understand the heart, then you must have time of around 10 hours, and then we can complete heart, but we will try to complete it in the 3 hours or 3 to 4 hours. And yeah, let's just get started with the blood vessels and its disorders, and yeah, let's just jump to the slides. So guys, first of all, arteries को 3 types में divide करा गया है according to their caliber and their histological features. So arteries are divided according to their caliber and certain histological features. So they are divided into, first is large or elastic arteries, second is medium and muscular arteries, and the third is the smallest arterial. So initially we will be discussing the physiology, thoda sa physiology, then we will be right away jumping to the pathology, right? So arteries are divided into 3: large, medium and small. So histologically, all the major arteries of the body have 3 layers in their walls, right? 3 layers in the walls. First is tunica intima, the innermost layer, then tunica media, medium or intermediate wali layer, and the tunica adventitia, the outermost layer. So these layers progressively decrease with the diminution in the size of the vessel. So first is tunica intima. This is the innermost coat of the artery, and it is composed of the lining endothelium, subendothelial connective tissue, and bounded externally by internal elastic lamina, and endothelium is a layer of the flattened cells adjacent to the flowing blood, and narrow junction exists between the adjoining endothelial cells through which certain materials pass, and the integrity of the endothelial cell is of paramount importance in maintenance of the vascular functions, since Damage to it is the most important event in the initiation of the thrombus formation at the site. And देखो, it is the innermost coat and it is composed of the endothelium, and then there is subendothelial connective tissue, and then it is elastic lamina, right? So initially endothelium is there, then subendothelial connective tissue is there, and then the elastic lamina is there. ठीक है? Endothelium is a layer of latent cells adjacent to the flowing blood, right? So here is the blood. So this is common sense wala thing hai. This is endothelium, and this is the lumen of the artery, and this is again the endothelium, right? And here is the blood, right? And endothelium is the layer of the flattened cells adjacent to the flowing blood. Narrow junctions exist between the adjoining endothelial cells through which certain materials can pass, right? And the integrity of the endothelial layer is of paramount importance in maintenance of the vascular functions, since damage to it is the most important event in the initiation of the thrombus formation at the site. Subendothelial tissue consists of the loose meshwork of connective tissue that includes myointimal cells, collagen, proteoglycans, elastin, tissue glycoproteins. So guys, जो इसके बाद वाली लेयर होती है ना, सब एंडोथेलियल लेयर, सो दैट इज having a loose meshwork of connective tissue that includes collagen, proteoglycans, elastin and matrix glycoproteins, right? And then जो elastic layer होती है, elastic lamina, so and that is the layer of elastic fibers having minute fenestrations, right? So initially endothelium is having gap junctions, then subendothelium, it is having many things: collagen, proteoglycan and elastin and matrix glycoproteins. Then elastic lamina is there, or internal elastic lamina is there, that is having elastin tissue, and right. Then tunica media, that is the intermediate layer. So tunica media is the middle coat of the arterial wall, bounded internally by the internal elastic lamina and externally by the elastic lamina. So this is internal elastic lamina. इसके बीच में आई हमारी intermediate layer, that is tunica media, और इसके ऊपर आ गया फिर से elastic. अब तो ये है external elastic layer and this is internal elastic layer, or you can say lamina. ठीक है? So in between these two, in between the internal elastic lamina and external elastic lamina, there is tunica media, right? So this layer is the thickest and consists of mainly of smooth muscle cells and elastic fibers. ठीक है? And the elastin and the external elastic lamina consists of the dense elastic tissue and is less well defined than the internal elastic lamina. So here we have discussed that the internal elastic lamina consists of elastic fibers that are having minute fenestrations, but in the external elastic lamina none of these things will be there. There will be elastin tissue that will be condensed and it will be thick and कुछ भी definition नहीं दिखेगी किसी भी चीज़ की, right? So tunica media we have completed. Then tunica adventitia, the outermost coat of the arteries, and it is the tunica adventitia. It consists of the loose meshwork of the connective tissue and some elastic fibers that merge with the adjacent tissues, and this layer is rich in lymphatics and autonomic nerve fibers, right? So this is the outermost layer and this will be the hardest or the toughest layer, right? And it is consists of the loose meshwork of the connective tissue and some elastic fibers, और आसपास वाले टिश्यू से भी ये merge कर सकती है, and this layer is rich in lymphatics and autonomic nerve fibers. Then the layers of the arterial wall receive nutrition and oxygen from two sources, right? So first is tunica intima, and the inner third of the media are nourished by the direct diffusion from the blood present in the lumen. So guys, we have discussed that endothelium consists of a gap junction through which only a few material can pass through. So that few material are first of all nutrients, right? So tunica intima and the inner one third. So this is the tunica intima and this is the inner one third of the media, tunica media. So these two layers get nutrition directly from the blood because these two layers are very close to the lumen or very close to the blood, so they can directly extract their nutrients from the blood, right? Then the outer two-third of the media and the adventitia are supplied by vasa vasorum, vessels or vessels, and the nutrient vessels arising from the parent artery. So guys, जो outer two-third of the media that is left, these layers, right? So this is 1/3 and this is 1/3. So this is the outer two-third of the media, right? Plus the tunica adventitia, they are supplied by vasa vasorum, the nutrient vessels arising from the parent artery. As the caliber of the artery decreases, the three layers progressively diminish, right? So जैसे जैसे इनका जैसे जैसे हमने बात करी थी कि सबसे पहले there is intermediate, large artery, intermediate and the smallest artery. So जैसे जैसे we move toward the smallest one, the differentiation of these three layers, they will just diminish, right? And then we will be having a small thin endothelial layer only when we talk about the smallest arteriole or capillaries, right? Thus there are structural variation in the three type of arteries. And what is that structural variation? First is large arteries. So as we have discussed, large arteries are most elastic arteries. Most elastic arteries का मतलब they can sustain a more amount of blood than normal blood, right? So अगर हम इसके अंदर imagine करो, let's imagine it can contain 100 ml of blood, but at times it can also sustain 200 ml of blood without bursting, right? So that's why this is called as elastic. Plus ये aorta का अपना जो एक recoil होता है ना, that is very 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 much, because aorta is the only artery that helps or that pumps the blood into whole body, right? Yes, it gets its power from left ventricle, it is true, but because of its elasticity, it enables to transport the whole blood. Then so aorta is one example. Then common carotid, major pulmonary, common iliac arteries. So they have very high content of elastic tissue in the media and thick elastic lamina, hence they are called as elastic arteries. Then medium sized arteries or muscular arteries, and these are branches of the elastic arteries, and all the three of the arterial wall are thinner than in the elastic arteries, right? So these are thinner, and the internal elastic lamina appears as a single wavy line, while the external lamina is less prominent, right? So here external lamina तो बिल्कुल एकदम diminish हो गई, खत्म हो गई, but still internal lamina is visible as a wavy line. Then arterioles, so these are the smallest branches. So they are having a diameter of 20 to 100 μm. So generally if we move further, they will be having only endothelial layer, Structurally they consist of three layers as in muscular arteries, but are much thinner and cannot be distinguished. The arterioles consist of a layer of endothelial cells in the intima, one or two smooth muscle cells in the media, and small amount of collagen and elastin tissue comprising the adventitia, and the elastic lamina are virtually lost. So guys, arterioles are the smallest branches of the with the internal diameter of 20 to 100 μm, and structurally they consist of the three layers as in the muscular arteries, but are much thinner and cannot be distinguished. Arterioles consist of a layer of endothelial cells in the intima, and one or the two smooth muscle cells in the media, and small amount of collagen and the elastic tissue comprising the adventitia, and the elastic lamina are virtually lost. And अगर हम arteriole से आगे बढ़ेंगे then हमें सिर्फ endothelial layers ही दिखेंगी. Now comes the disorder. First is arteriosclerosis. So arteriosclerosis हम अच्छे से करेंगे. Arteriosclerosis is a general term used to include all the conditions with thickening and hardening of the arterial walls, and the following morphological entities are included under arteriosclerosis. So arteriosclerosis is the general term used to include all the arterial thickening and hardening, right? And the following morphological entities are included under arteriosclerosis. So first is senile arteriosclerosis, then hypertensive arteriosclerosis, Monkeyberg's arteriosclerosis, and this is the most important thing. इसका अभी तक some people or even in internship they don't know what is a Monkeyberg arteriosclerosis is. So it is a medial calcific sclerosis जो अब अभी आगे डिस्कस करेंगे अच्छे से. Then atherosclerosis, that is the most important thing. यूनिवर्सिटी एग्जाम का ये लॉन्ग क्वेश्चन आ सकता है. And Monkeyberg's arteriosclerosis शॉर्ट क्वेश्चन आ सकता है, right? And ये दोनों is not so much of importance in the university examination, but as per MCQ they are important. The last named atherosclerosis is the most common and the most important form of the arteriosclerosis, and if not specified, the two terms are used interchangeably with each other, right? Senile arteriosclerosis. So let's just start with the senile arteriosclerosis. So senile arteriosclerosis is the thickening of the media and the intima of the arteries seen due to aging. So as the name suggests, senile means aging. So this is the thickening of the media or intima of the arteries seen due to aging, and the changes are non-selective and affects most of the arteries, right? So they are non-selective, and मतलब कि हर एक आर्टरी में भी हो सकते हैं irrespective of its location, its name and its function, right? So it can be there in your portal system, it can be there in your aorta, it can be there in your carotid arteries, and हर जगह, ठीक है? So the changes are non-selective, but a specification is there that it mostly affects the arteries. Veins are less affected. These are possibly induced by stress and strain on the vessel wall during life. So stress and strain on the vessel wall means that prolonged hypertension will cause this thing, or right, prolonged hypertension will cause this thing. So morphological features की अगर हम बात करें, then fibroelastosis. So the intima and media are thickened due to the increase in elastic and collagen tissue. So the intima and the media are thickened due to the increase in the elastic and the collagen tissue. Then elastic replication. The internal elastic lamina is split or reduplicated so that two wavy layers are seen. So guys, elastic reduplication, the internal elastic lamina that we have discussed is split or reduplicated so that two wavy layers are seen here now, and eventually the fibrotic changes result in age related elevation of the systolic BP. So guys, first is fibroelastosis. The media and the intima are thickened due to the increase in the elastic and the collagen tissue. Second is elastic reduplication. The internal elastic lamina is split or reduplicated so that two wavy layers are seen, and eventually the fibrotic changes, they result in age related elevation of the systolic BP, right? Then hypertensive arteriosclerosis. Hypertension is basically the lateral pressure that is exerted on the blood vessel, right? So this is the lateral pressure that is exerted on the blood vessel due to blood, right? So when this pressure is high, we say that patient is having hypertension. Means that when the high BP, high blood pressure is prolonged, right, then we will be referring it as hypertension, right? Arteriosclerosis is the term used to describe three morphological forms of vascular disease affecting arterioles and small muscular arteries. These are Hyaline arteriosclerosis, hyperplastic arteriosclerosis, and necrotizing arteriolitis. And all the three types are common in hypertension but may occur due to other causes as well. So guys, mainly hypertension कब किस की वजह से, if hyaline is deposited in the walls of blood vessel, so blood vessels will be hardened. देखो क्या होना चाहिए कि this is pressure and this is the lateral pressure that is exerted by blood, and if there is a slight increase in, that is, let's take an example. If earlier was 130 mm of Hg, that is high, but ठीक है, now there is increase in 10 mm of Hg, but now patient's artery are hyalinized. Hyalinized means hard means now if the pressure is there, तो ये बिल्कुल भी expand नहीं करेंगी and they will be unable to expand, and if this thing happened, then this 10 mm of Hg will, so ultimately 140 mm of Hg हो गया, but अल्टीमेटली ये बढ़ के 160 mm ऑफ Hg आ जाएगा, बिकॉज इलास्टिसिटी नहीं है एंड बहुत ही ज़्यादा प्रेशर लगेगा, क्योंकि it will try to contract itself, and if this will be contracting, then the pressure will be more at the lateral sides, and thus this 140 mm will be showing its result as 160 mm of Hg. So this is a difference between a hyalinized and a normal artery, राइट. और नॉर्मल आर्टरी में, एक नॉर्मल इंडिविजुअल में समटाइम्स देयर आर कंडीशंस जब बीपीआई हो जाता है, राइट. प्रोफेसर ने कुछ बोल दिया, बॉस ने कुछ बोल दिया, तो बीपीआई हो गया, लड़ाई हो गई, बीपीआई हो गया. बट अल्टीमेटली व्हाट विल हैपन इज दीज आर्टरीज विल एक्सपैंड एंड काफ़ी सारा ब्लड आर इजीली पास थ्रू हो जाएगा. बट द प्रॉब्लम कम्स व्हेन these arteries fails to expand, and this is the condition of hyalinization, ठीक है. and all the three types are hyperplastic के अंदर hyperplasia हो गया, right. necrotizing arteriolitis, so this is the inflammation, right, and that is causing necrosis. So inflammation किसी भी वजह से हो सकता है, either any noxious stimulus, any foreign organism, right, and all the three types are common in hypertension. So all these three things can cause hypertension, right. And then Hyaline arteriosclerosis. Hyaline sclerosis is a common arterial lesion that may be seen physiologically due to aging, or may be pathologically in the benign nephrosclerosis in the hypertension, and as a part of microangiopathy in diabetics. So the visceral arterioles are particularly involved, and the vascular walls are thickened, and the lumen is narrowed and even obliterated. So this is what I was talking about. Microscopically, the thickened vessel wall shows structureless eosinophilic hyaline material in the intima and the media. Pathogenesis, the exact pathogenesis is not known. However, the following hypotheses have been proposed. First is, the lesion result most probably from the leakage of the components of the plasma across the vascular endothelium, and this is the substantiated by the demonstration of the Ig's complement, fibrin, lipid in the lesion, and the permeability of the vessel wall is increased due to the hemodynamic stress in the hypertension and the metabolic stress in the diabetes, so that these plasma components leak out and get deposited in the vessel wall. right? And thus it appears as hyalinization. So this was the one theory that was proposed. Then an alternative possibility is that the lesion may be due to the immunological reaction, right? It can be autoimmune. Then some have considered it to be a normal aging process that is exaggerated in the hypertension and diabetes mellitus. So some propose that this is a normal aging process, but if the patient is having hypertension or diabetes mellitus, then this would be more, right? Then this phenomena will be increased. Then hyperplastic arteriosclerosis. The hyperplastic or the proliferative type of the arteriosclerosis is a characteristic lesion of malignant hypertension. Other causes include hemolytic uremic syndrome, scleroderma, and toxemia of pregnancy. Then morphological features. The morphological changes affect mainly the intima, especially of the interlobular arteries in the kidney. These three types of intimal thickening may occur. So first is onion skin lesion, mucinous intimal thickening, and fibrous intimal thickening. So guys, hyperplastic के अंदर there is proliferation, right, and there is a characteristic lesion of malignant hypertension, and other causes can be hemolytic uremic syndrome, scleroderma, and toxemia of pregnancy. Morphological features कैसे दिखेंगे? Onion skin lesion consists of the loosely packed concentric layer of the hyperplastic intimal smooth muscle cells like the bulb of an onion, and the basement membrane is also thickened and reduplicated. So onion का कभी आपने देखा हो तो it looks like this, concentric circles. So ऐसा कुछ artery में change आ जाता है, and it looks like onion skin lesion. So that's why we call it as onion skin lesion. Then mucinous intimal thickening is the deposition of the amorphous ground substance, probably proteoglycans, with scanty cells. Fibrous intimal thickening is less common and consists of bundles of collagen, elastic fibers, hyaline deposits, and severe intimal sclerosis result in narrowed and obliterated lumen. With time, the lesions become more and more fibrotic, right? So pathogenesis, the pathogenesis is the same, it is not known. Probably the changes result from the endothelial injury from the systemic hypertension. As you know, we have discussed now, recently we have discussed that मैंने अभी आपको बताया कि this lateral pressure लगा और ये आर्टरी हो गई एक्सपैंड और उसके बाद बीपी हो गया नॉर्मल. बट if the patient is having now hypertension or constant rise in BP, constant rise in BP कैसे हो सकता है? increased salt intake है, water ज़्यादा है, तो constantly arteries पर pressure जाएगा और ये कितना expand होंगी, right? So एक टाइम एक लिमिट होती है, लिमिट क्रॉस होने के बाद क्या होगा? this increase in the pressure will be injurious to the blood vessel wall, and ये इसको इंजरी पहुंचाती जाएगी and thus फिर ये इंजरी की वजह से there can be fibrous intimal thickening, और ये थिक हो जाएगी और उसके बाद ये further expand नहीं होगी, right? So that's why BP काफी ज़्यादा shoot out भी हो सकता है, right? Because after changes the vessels also try to come together, मतलब अंदर की साइड प्रेशर लगाते हैं, ब्लड बाहर की तरफ लगा रहा है वो अंदर की तरफ, तो अल्टीमेटली जब आप देखोगे ना तो बीपी काफी ज्यादा ही आता है. अगर आप समझ पा रहे हो मैं क्या कहना चाह रहा हूं तो यू कैन इजिली अंडरस्टैंड द थिंग्स, राइट. एंड होल पैथोलॉजी, होल मेडिसिन एंड होल फार्मा इज ऑफ अंडरस्टैंडिंग. अगर आप समझ सकते हो चीजें देन यू कैन डू the things easily and you can do wonders and your patients would be happy from you because आप रट के नहीं आए हो. Immunological damage leading to the increased permeability and a healing reaction occurs in the form of proliferation of the smooth muscle cells with the fibrosis. या ये चीज़ मैंने अभी बताई कि आपकी वेसल वॉल को हुई इंजरी हील होगी, हील होने के लिए आएगा कोलेजन आया, कोलेजन आके डिपॉजिट हो गया. कोलेजन इज अ हार्ड मटेरियल, इट इज नॉट इलास्टिक, सो इट इज़ नॉट सो मच इलास्टिक जैसे वो पहले था फिजियोलॉजिकली. तो अब इसकी वजह से हार्डनिंग हो गई. हार्डनिंग की वजह से इट विल ट्राई टू ब्लड विल ट्राई टू पुश द आर्टरी आउट, बट आर्टरी नहीं होगी. आर्टरी अंदर की साइड प्रेशर लगाएगी और अल्टीमेटली बीपी बढ़ जाएगा, राइट. सो अल्टीमेटली हाइपरटेंशन विल बी कॉजिंग hypertensive crisis, right. So that's why this is the remodeling process. तो ये रीमॉडलिंग को हम ब्लॉक करना चाहते हैं. तो तभी हम हाइपरटेंशन की फटाफट से हम कहते हैं कि स्टार्ट मेडिकेशन. एंड बीपी शुड बी if your initial BP was 180 mm of Hg systolic, then our goal is to minimize it, और तो उसको हम 150 करने का गोल होगा, राइट. 140 करने का गोल होगा. एंड अल्टीमेटली आफ्टर 140 वी विल ट्राई टू शिफ्ट इट टू 130. एंड इफ 130 is achieved, then life expectancy is increased and prognosis is really well, right. I hope कि आप सबको समझ में आ रहा होगा. Then necrotizing arteriolitis. So necrotizing arteriolitis, in cases of severe hypertension and malignant hypertension, parts of the small arteries and the arterioles show changes of the hyaline sclerosis, and parts of these show necrosis, or necrosis may be superimposed or on hyaline sclerosis. However, hyaline sclerosis may not always be present in the vessel wall. So necrotizing arteriolitis. So in the cases of severe hypertension and malignant hypertension, parts of the small arteries and arterioles show changes of the hyaline sclerosis, like we have discussed. But a part of these show necrosis. So this can show necrosis, or necrosis may be superimposed on hyaline sclerosis. So कुछ changes पर hyaline changes हो सकते हैं, कुछ changes पर necrosis हो सकता है, right. And ultimately कई बार क्या हो सकता है, हाइलीन के ऊपर देयर इज सुपर इम्पोजिशन ऑफ द नेक्रोसिस, राइट. सो मॉर्फोलॉजिकल फीचर्स में क्या दिखेंगे, बिसाइड द चेंजेस ऑफ हाइलीन स्क्लेरोसिस, द चेंजेस ऑफ द नेक्रोटाइजिंग आर्टियोलाइटिस इंक्लूड फिब्रिनॉइड नेक्रोसिस ऑफ द वेसल वॉल, fibrinoid necrosis of the vessel wall, acute inflammatory infiltrate of the neutrophils because itis आ गया, ठीक है, in the adventitia, edema, hemorrhages, right. Then pathogenesis. Since necrotizing arteriolitis occur in the vessels in which there is sudden and great elevation of the pressure, the changes are said to result from direct physical injury to the vessel wall, right. Then Monkeberg's arteriosclerosis or medial calcific sclerosis. So this is the most important thing, and you all have to understand this thing. Monkeberg's arteriosclerosis is the calcification of the media of the large and the medium size arteries. मतलब कि इलास्टिक प्लस मस्कुलर आर्टरीज में ये देखने को मिलता है, राइट. Especially of the extremities and of the genital tract, right. So extremities plus genital tract in the persons past the age of 50, right. The condition occurs as an age-related degenerative process and therefore an example of dystrophic calcification and has a little or no clinical significance. So guys, this is a condition that takes place as a age-related disorder that is prevalent after 50 years of age, and इसके अंदर क्या होता है, dystrophic calcification. And dystrophic calcification, we have not took a session on this. This is a topic of general pathology, so इसको भी हम ले लेंगे, but हम इसी में थोड़ा सा कोशिश करेंगे कि हम इसको कर लें. However, medial calcification also occurs in some pathological states like pseudoxanthoma elasticum and idiopathic arterial calcification of infancy. So medial calcification occurs in some pathological states like pseudoxanthoma elasticum and in idiopathic arterial calcification of infancy. Then morphologic features. Medial calcification is often an incidental finding of X-ray of the affected sites having muscular arteries, and the deposition of the calcium salts in the media produces pipe stem like rigid tubes. So guys, medial calcification is often an incidental finding in X-ray of the affected site of the muscular arteries. The deposition of the calcium salts in the media produces pipe stem like rigid tubes, and these tubes are visible, and the major characteristic feature is that without even causing narrowing of the lumen. Microscopically, Monkeyberg arteriosclerosis is characterized by the deposits of the calcium salts in the media without any associated inflammatory reaction, while the intima and the adventitia are spared. Right, so intima में भी कुछ नहीं होता, adventitia में भी कुछ नहीं होता. The medial aspect is affected, and in the medial aspect only there is calcium deposition. Often coexistent changes of the atherosclerosis are present, altering the histological appearance. Right, so initially it will be only medial calcification, and it will be if you find in an X-ray, you can see a rigid tube, right, and calcium की वजह से it would be opaque and easily visible in the X-ray. And pathogenesis of this condition is not known, but it is considered as age-related physiological change due to the prolonged effect of vasoconstriction. Right. Then atherosclerosis. This is the most important full question that will be asked in your university examination, and viva में भी, and MCQ point of view से भी बहुत ही ज़्यादा important topic है. This is the most important topic of this chapter, and another Kaposi sarcoma is most important topic of this chapter. University examination point of view से. Then definition. Atherosclerosis is a thickening and hardening of the large and the medium sized arteries, primarily due to the involvement of the tunica intima. Right, so इसके अंदर there is involvement of the tunica intima, but Monkeyberg's arteriosclerosis के अंदर tunica media. Right, so this is the point of difference. And उसके अंदर calcium deposit हो रहा था, इसके अंदर fat deposit हो रहा है. Right, so काफी ज़्यादा difference है. Right. So it is characterized by the fibrofatty plaques and erythemas, and the term atherosclerosis is derived from the athero, referring as a soft lipid rich material in the center of the atheroma, and sclerosis or scarring referring to the connective tissue in the plaques. And atherosclerosis is the commonest and the most important of the arterial diseases, and इसकी वजह से there is CAD, there is angina, there is MI, there is stroke, and all the things. Even diabetic foot के अंदर भी atherosclerosis का prevalence है. And though any large and the medium sized artery may be involved in atherosclerosis, the most commonly affected is aorta, coronaries, and the cerebral artery system. Therefore, the major clinical symptoms or syndromes resulting from ischemia due to atherosclerosis are as under: heart पे angina, MI, heart attacks; brain पे transient cerebral ischemia, cerebral infarcts and strokes. Then other sequelae are peripheral vascular disease, aneurysmal dilatation due to the weakened arterial walls. So guys, how weakened arterial walls? नेक्रोसिस हो गया और इस्कीमिया हो गया, इस्कीमिया के बाद हो गया नेक्रोसिस. तो ये जो वॉल पे नेक्रोसिस हुआ, दिस इज वीकेंड. ये वीकेंड हो गई तो यहाँ हो जाएगा डायलेटेशन. यहाँ डायलेटेशन हुआ तो यहाँ ऐसे बैलून जैसा बन जाएगा, यहाँ ब्लड भी फिल हो जाएगा. सो दिस इज अ एनेरिज्म. राइट. Chronic ischemic heart disease, ischemic encephalopathy, mesenteric arterial occlusion. Right. Then etiology. Atherosclerosis is widely prevalent in industrialized countries. However, majority of the data on etiology are based on the animal experimental work and epidemiological studies. The incidence of the atherosclerosis quoted in the literature is based on the major clinical syndrome produced by it. The most important interpretation being that the death from the MI is related to underlying atherosclerosis, and most of the north side males are affected from the atherosclerosis or CAD or angina or MI, right? And after 65 years of age females are also affected. So initially 40-50 की age में females are not affected because of the estrogen and all the theories जो कि हैं, बट मेल्स तो काफ़ी सारे अफेक्टेड हो जाते हैं 40 to 60 years of एज में. फीमेल्स आर जनरली prevalent after 55 to 65 years of age. And right, and the major cause I would tell you is dyslipidemia, because north side पर there are more of Punjabis in Delhi, in Punjab, and in Haryana, basically these states, they try to take more of dairy products, ghee, butter and all, and thus they have a habit of taking butter, ghee in every meal, and that to a very large amount. That's why they suffered from dyslipidemia, and this dyslipidemia it ultimately causes CAD. Even I am a Punjabi, and मतलब मैं भी काफ़ी ज़्यादा मोटा था पहले. आई वॉज 98 kgs, और बिकॉज ऑफ ऑल दिस थिंग, बिकॉज ऑफ आर ईटिंग सिनेरियोज, एंड दिल्ली में तो काफ़ी ज़्यादा होता ही है, राइट. एंड अब सर्दियाँ शुरू हो गई हैं, तो बहुत ही ज़्यादा ये अभी फिर से स्टार्ट होने वाला है. बट नाउ आई एम 70, और अब आई ट्राई टू नॉट टेक द major dairy products, right? And cardiovascular disease is mostly related to the atherosclerosis, coronary heart disease, ischemic heart disease, and is the most common cause of the premature death in the developed countries of the world. And right now Remo sir को भी MI हुआ है, and वो काफ़ी सारी एक्सरसाइज, डांस इज इटसेल्फ अ वर्कआउट. सो आई डोंट नो हाउ वाई हुआ ये, बट अल्टीमेटली काफ़ी सारे कॉज भी हो सकते हैं. हमें कुछ अभी ऐसा आइडिया नहीं है, उनकी डाइट का भी नहीं पता कि भाई डिस्लिपिडीमिया, तो लगता नहीं है कि उनको कोई कोलेस्ट्रॉल ज़्यादा होगा, LDL कोलेस्ट्रॉल ज़्यादा होगा, और हमें कुछ ऐसा पता भी नहीं कि सब्सटेंस अब्यूज़ वगैरह के बारे में. सो आई विल नॉट कमेंट ऑन दैट. बट रिसेंट न्यूज़ में MI की न्यूज़ आई थी रेमो सर की, सो मैंने कहा कि बता देना चाहिए. And it is estimated that by the year 2020, cardiovascular diseases, mainly atherosclerosis, will become the leading cause of the total global disease burden. And systematic large scale studies, हाँ इसके साथ एक और चीज़, there is one country, I don't know the, मतलब इतना ज़्यादा मेरे को डीप में नहीं पता, बट आई नो कि एक कंट्री है जो मेन अपने पानी में ही स्टैटिन्स मिला के देती है. जो मेन उनके वाटर सप्लाई आती है उसमें ही स्टैटिन्स मिला के देते हैं एट अ वेरी लो डोज. सो उस स्टैटिन से क्या होता है कि जो उनका डिस्लिपिडीमिया होता है वो सब ठीक रहता है, और उनको ज़्यादा ऐसे बिल्कुल एकदम प्रेवलेंट CAD नहीं होता, राइट. Because major cause is this only, dyslipidemia. So first of all चलो हम मेजर रिस्क पढ़ लेते हैं. एंड फर्दर ये दो हेडिंग्स में दिए हैं. मेजर रिस्क फैक्टर, मॉडिफाइबल लाइफस्टाइल और थेरेपी. सो मेजर लाइफस्टाइल पे है. सबसे पहले तो डिस्लिपिडीमियाज, हाइपरटेंशन, डायबिटीज मेलाइटस एंड स्मोकिंग. स्मोकिंग इज़ द वन ऑफ द मेजर कॉज जो कि कॉज कर सकता है हार्ट अटैक. देन कॉन्स्टिट्यूशनल risk factors that you cannot modify, increasing age, male sex predominance, genetic abnormalities, familial and racial predispositions. So इसको हम ठीक नहीं कर सकते, but we can modify our diet, we can modify our lifestyle so that we try to prevent these things. Then second and non-traditional emerging factors, This group includes the host of the factor whose role in the atherosclerosis is minimal and in some cases even uncertain. So first of all is major risk that is modifiable. First is lipid disorders, hypertension, cigarette smoking, diabetes mellitus. So and then yeah, we have already discussed lipid disorders. So when your body is having high HDL, then it's good, but LDL कम रहना चाहिए. HDL is high density lipoprotein और lipids, and ये आपको मिलते हैं ड्राई फ्रूट से, वॉलनट्स, एंड दीज आर ओमेगा 6, 9, 3, 6 and 9 फैटी एसिड्स, एंड दिस इज़ वेरी एसेंशियल फॉर योर बॉडी. LDL आपको मिलता है बटर और इन सब चीज़ों से, तो ये आपको नहीं लेना चाहिए. लेना चाहिए एट अ लोअर अमाउंट, बिकॉज ghee and butter is also needed for the testosterone, and right, and it is proven that because these are saturated fats, and saturated fats आपकी बॉडी में काफ़ी ज़्यादा इम्पॉर्टेंट है स्किन हेल्दी के लिए एंड ऑल दैट. हम उतना न्यूट्रिएंट्स पॉइंट ऑफ व्यू में नहीं जाएंगे, बट सैचुरेटेड फैट्स आर नीडेड, बट excess of everything is bad, and अगर deficiency है तो भी it is bad. So एक normal amount में you have to take saturated fatty acids as well. Then cigarette smoking, it is the most common cause, and it is the again most common cause of Raynaud's phenomena as well, and Buerger's disease as well, mainly Buerger's disease, and diabetes mellitus may be diabetes mellitus again is the major risk factor that can cause atherosclerosis. Then constitutional risk factors जो कि हम change नहीं कर सकते. First is age. Atherosclerosis is age related disease. So after 50 years थोड़ी ऐसे problem start हो सकती है. So the early lesions of the may be present in the childhood as well, but significant lesions जो कि symptoms produce करेंगे that are around 50 to 55 years of age. Fully developed erythromatous plaque usually appear in the 4th decade and beyond. Evidence in support comes from the high death rate from the IHD in this age group. Then second is sex, that is having a male predominance, and the incidence and the severity of the atherosclerosis are more in male while in female, and the changes appear a decade earlier in, so मेल में 45 से स्टार्ट हो जाता है एंड फीमेल्स में अराउंड 55, जैसे मैंने आपको पहले बताया. The prevalence of atherosclerotic IHD is about 3 times higher in men in the 4th decade than in women, and the difference slowly declines with the age but remains higher at all the ages in men, and the lower incidence of the IHD in women, especially in premenopausal age. After पोस्ट मेनोपॉजल तो सब कुछ खराब हो जाता है. पोस्ट मेनोपॉजल में द फैट गेट्स डिपॉजिटेड एंड या. थर्ड इज जेनेटिक फैक्टर्स. कई बार जेनेटिक फैक्टर्स प्ले अ सिग्निफिकेंट रोल इन एथेरोजेनेसिस, एंड हेरिडिटरी डिरेंजमेंट्स ऑफ द लाइपोप्रोटीन मेटाबॉलिज्म प्रीडिस्पोज द इंडिविजुअल टू हाई ब्लड लिपिड लेवल एंड familial hypercholesterolemia. And familial and racial factors. The familial predisposition to the atherosclerosis may be related to other risk factors like diabetes, hypertension, hyperlipoproteinemia. And racial differences too exist, and blacks have generally less severe atherosclerosis than whites. And emerging risk factors क्या क्या है? Emerging risk factors are higher incidence of the atherosclerosis in the developed countries and low prevalence in the underdeveloped countries, suggesting that there is a role in diet or right. तो जो भी डेवलप्ड कंट्रीज़ में लोग ज़्यादा खाते हैं, अंडर डेवलप्ड में कम खाते हैं. तो अंडर डेवलप्ड में देर आर लेस चांसेस, बट डेवलप्ड में देर आर हाई चांसेस. देन मेटाबॉलिक सिंड्रोम कैरेक्टराइज बाय एब्डोमिनल ओबेसिटी. एब्डोमिनल ओबेसिटी जिनको ऐसे एब्डोमेन पर एकदम ज़्यादा फैट होता है और बाकी पूरी बॉडी पर नहीं होता, दैट ऑल्सो इज़ अ प्री डिस्पोज कंडीशन with a glucose intolerance, insulin resistance, dyslipidemia, hypertension. Then use of exogenous hormones, oral contraceptive by women, or endogenous estrogen deficiency has been shown to have an increased risk of developing MI or stroke. Then physical inactivity, lack of exercise are associated with the risk of developing atherosclerosis and its complications. Then stressful lifestyle, termed as type A behavior pattern, characterized by aggressiveness, competitive drive, ambitiousness, and a sense of urgency, associated with the enhanced risk of IHD compared to type B behavior of relaxed and happy-go-lucky type. Then hypercystinemia, due to the elevated serum homocysteine level from a low folate and vitamin B12, have a relationship with the coronary artery disease and its consequences. Then patients with homocystinuria, an uncommon inborn error of metabolism having hypercystinemia, have also been reported to have early atherosclerosis and coronary artery disease. Then prothrombotic factors are the elevated fibrinogen levels favor formation of thrombi, which is gravest complication of atherosclerosis. Then role of infectious, particularly chlamydia, pneumonia, and viruses such as herpes virus, cytomegalovirus, has been found in the coronary atherosclerosis lesions by causing inflammations. Possibly infections may be acting in the combination with some other factors. Then markers of inflammation such as elevated C-reactive protein, acute phase reactant, correlate with the risk of developing atherosclerosis. Insudation hypothesis. The concept of hypothesized by Virchow in 1856. So the concept of hypothesized Virchow in 1856, that atherosclerosis is form of cellular proliferation of the intimal cells resulting into the increased imbibing of the lipids from the blood, came to be called as the lipid theory, and modified form of this theory is currently known as response to injury hypothesis and is nowadays the most widely accepted theory. And encrustation hypothesis, the proposal put forth by Rokitansky in 1852, that atheroma represented a form of encrustations of the arterial wall from the components of the blood forming thrombi composed of the platelets, fibrin, and leukocytes, was named as encrustation theory and thrombogenic theory. Currently, the pathogenesis of the atherosclerosis is explained on the basis of the following two theories. First is reaction to injury hypothesis. Second is monoclonal theory. So, reaction to injury hypothesis. This theory is most widely accepted and incorporates aspects of the two older historical theories of the atherosclerosis, the lipid theory of Virchow and thrombogenic theory of Rokitansky. The original response to injury theory was first described in 1873, according to which the initial event in the atherogenesis was considered to be endothelial injury followed by the smooth muscle cell proliferation, so that the early lesions, according to this theory, consist of smooth muscle cells mainly. So the original response to injury theory was the first described in 1973, according to which the initial event of atherogenesis was considered to be endothelial injury followed by smooth muscle cell proliferation, so that the early lesion, according to this theory, consists of smooth muscle cells mainly. Then the modified response to injury hypothesis was described subsequently in 1993, implicates lipoprotein entry into the intima as well as the initial event followed by lipid accumulation in the macrophages, foam cells now, which according to modified theory are believed to be the dominant cells in the early lesions. Then endothelial injury. It has been known for many years that endothelial injury is the initial triggering event in the development of the lesions of the atherosclerosis. Actual endothelial denudation is not an essential requirement, but the endothelial dysfunction may initiate the sequence of events, and numerous cases ascribed to endothelial injury in the experimental animals are mechanical trauma, hemodynamic forces, immunological and chemical mechanism, metabolic agent are metabolic agent as chronic dyslipidemia, homocysteine, circulating toxins from systemic infections, viruses, hypoxia, radiation, carbon monoxide, tobacco products. In human, two of the major risk factors which act together to produce endothelial injury are hemodynamic stress from hypertension and chronic dyslipidemia, and the role of the hemodynamic processes in causing the endothelial injury is further supported by the distribution of the Atheromatous plaque at points of the bifurcation of branching of the blood vessels, which is under greatest shear stress. Then the intimal smooth muscle cell proliferation. Endothelial injury causes adherence, aggregation, and platelet release reaction at the site of exposed subendothelial connective tissue and infiltration by inflammatory cells. Proliferation of the intimal smooth muscle cell and the production of the extracellular matrix are stimulated by various cytokines such as interleukin 1, TNF alpha, released from the invading monocyte macrophages, and by activated platelets at the site of the endothelial injury. These cytokinins lead to the local synthesis of the following growth factors having distinct roles in the plaque evolution. First is platelet derived growth factor and fibroblast growth factor. PDGF and FGF stimulate the proliferation and migration of the smooth muscle cells from their usual location in the media into the intima. Transforming growth factor B, TGF beta and interferon gamma derived from the activated T lymphocyte within lesions regulate the synthesis of collagen by the smooth muscle cells. The smooth muscle cell proliferation is also facilitated by the biomolecules such as nitric oxide and endothelin released from the endothelial cells. Intimal proliferation of the smooth muscle cells is accompanied by the synthesis of the matrix protein, collagen, elastin fibers, and proteoglycans. Role of the blood monocyte. Plasma LDL on the entry of the intima undergoes oxidation, and the oxidized LDL found in the intima performs the following all important functions on the monocyte and endothelium. First, for monocyte, oxidized LDL acts to attract, proliferate, and immobilize and activate them, as well as it readily taken up by the scavenger receptor on the monocyte to transform it to a lipid laden form cells. And for endothelium, oxidized LDL is cytotoxic. Death of the foam cell by apoptosis releases lipid to form lipid core of the plaque. Then role of the dyslipidemia, as stated already, chronic dyslipidemia in itself may initiate the endothelial injury and dysfunction by causing the increased permeability, and in particular hypercholesterolemia with increased serum concentration of LDL promotes formation of the foam cells, while high serum concentration of LDL has anti-atherogenic effect. Then thrombosis, as apparent from the foregoing, endothelial injury exposes the subendothelial connective tissue, resulting in the formation of the small platelet aggregates at the site and causing proliferation of the smooth muscle cells. This causes a mild inflammatory reaction which together with foam cells is incorporated in the Atheromatous plaque, and the lesions enlarge by attaching fibrin and the cells from the blood, so that thrombus becomes a part of Atheromatous plaque. Then monoclonal hypothesis. This hypothesis is based on the postulate that proliferation of the smooth muscle cell is the primary event, and that is the this proliferation is monoclonal in origin, similar to the cellular proliferation in the neoplasm. And the evidence cited in support of monoclonal hypothesis is the observation on proliferated smooth muscle cells in the Atheromatous plaques, which have only one of the two forms of the glucose 6-phosphate dehydrogenase isoenzyme, suggesting the monoclonality in the origin. And the monoclonal proliferation of the smooth muscle cells in the atherosclerosis may be initiated by the mutation caused by exogenous chemicals, example cigarette smoke, endogenous metabolites, lipoproteins in some viruses, Marek's disease virus in chickens, and herpes virus. Then morphological features. Early lesions in the form of diffuse intimal thickening, fatty streaks, and gelatinous lesions are often the forerunners in the evolution of the atherosclerotic lesions. However, the clinical disease states due to the luminal narrowing in the atherosclerosis are caused by fully developed atheromatous plaque and complicated plaque. Fatty streaks and dots. Fatty streaks and dots on the intima by themselves are harmless, but may be the precursor lesion for the atheromatous plaques, and they are seen in all races of the world and begin to appear in the first year of the life. And however, they are uncommon in the older persons and are probably absorbed. They are especially prominent in the aorta and other major arteries, and more often on the posterior wall of the posterior wall than the anterior wall. Grossly, the lesions may appear as flat or slightly elevated and yellow. They may be either in the form of small multiple dots about 1 mm in size, or in the form of elongated beaded streaks. Microscopically, fatty streaks lying under the endothelium are composed of closely packed foam cells, then lipid containing elongated smooth muscle cells, and a few lymphoid cells. Small amount of extracellular lipid, collagen and proteoglycans are also present. Gelatinous lesion. Gelatinous lesion develop in the intima of the aorta and other major arteries in the first few months of life. Like fatty streaks, they may also be precursors of plaque. They are round, oval, circumcised, grey elevation, about 1 centimeter in diameter. Then microscopically, gelatinous lesions are foci of increased ground substance in the intimal with the thinned overlying endothelium. Then atheromatous plaque, a fully developed atherosclerotic lesion, is called as atheromatous plaque, also called as fibrous plaque, fibrofatty plaque, or atheroma. Unlike fatty streaks, atheromatous plaques are selective in different geographic location and races and are seen in advanced age. These lesions may develop from progression of the early lesion of the atherosclerosis just described, and most often and the most severely affected and is the abdominal aorta through, though the smaller lesions may be seen in the descending thoracic aorta and thoracic arc, and the major branches of the aorta around the ostia are often severely involved, and especially the iliac, femoral, carotid, coronary, and the cerebral arteries. Grossly, atheromatous plaque are the white to yellowish white lesions varying in the diameter from 1 to 2 centimeter and raised on the surface by a few millimeters to the centimeters in the thickness. Cut section of the plaque reveals the luminal surface as a firm white fibrous cap and a central core composed of yellow to yellow-white soft porridge-like material. Hence, it is named as atheroma. Microscopically, the appearance of the plaque varies depending upon the age of the lesion. So, superficial luminal part of the fibrous cap is covered by endothelium and is composed of the smooth muscles, dense connective tissues, and extracellular matrix containing proteoglycans and collagen. Cellular area under the fibrous cap is comprised by the mixture of macrophages, foam cells, lymphocytes, and a few muscle cells which may contain lipid. Deeper central soft core consists of extracellular lipid material, cholesterol clefts, fibrin, necrotic debris, lipid-laden foam cells, and in older and more advanced lesions, the collagen in the fibrous cap may be dense, hyalinized, smooth muscle cells. They may be atrophic, and foam cells are fewer. कॉम्प्लिकेटेड प्लैक्स की अगर हम बात करें तो वेरियस पैथोलॉजिकल चेंजेस अकर इन द फुली डेवलप्ड एथेरोमेटस प्लैक एंड दीज चेंजेस इंक्लूड द calcification, ulceration, thrombosis, hemorrhage, aneurysmal dilatation, and it is not uncommon to see more than one form of complication in a plaque. Then calcification occurs more commonly in advanced atheromatous plaque, especially in the aorta and coronaries, and the diseased intima cracks like an eggshell when the vessel is incised and open. Microscopically, the calcium salts are deposited in the vicinity of the necrotic area and in the soft lipid pool deep in the thickened intima, And this form of atherosclerotic intimal calcification differs from monkey bar medial calcification um, uh, that affects only tunica media, right? So this is affecting intima. Then now comes the, wait a second. So ulceration, um, wait a second. Yeah. Ulceration. The layers covering the soft pultaceous material of an erythema may ulcerate as a result of hemodynamic forces and uh, mechanical trauma. This result in discharge of the emboli composed of the lipid material and debris into the bloodstream, leaving a shallow, rugged ulcer with yellow lipid debris in the base of the ulcer, and occasionally atheromatous plaque in the coronary artery may suddenly rupture into the arterial lumen forcibly and cause thromboembolic occlusion. Right? And thrombosis. The ulcerated plaque and the areas of the endothelial damage are vulnerable sites for the formation of the superimposed thrombi. These thrombi may get dislodged and become emboli and lodged elsewhere in the circulation, and they may get organized, incorporated into the arterial wall as mural thrombi, and mural thrombi may become occlusive thrombi which may subsequently recanalize, and काफ़ी सारी चीज़ें हो सकती हैं. Then hemorrhage. Intimal hemorrhage may occur in the atheromatous plaque either from the blood in the vascular lumen through an ulcerated plaque or from the rupture of the thin-walled capillaries that vascularize the atheroma from the adventitial vasa vasorum. And hemorrhage is particularly a common complication of the coronary arteries. The hematoma formed at the site contain numerous hemosiderin-laden macrophages. Aneurysm formation. Though atherosclerosis is primarily an intimal disease, advanced lesions are associated with secondary changes in the media and adventitia. The changes in the media include atrophy and thinning of the media and fragmentation of the internal elastic lamina. Then the adventitia undergoes fibrosis and some inflammatory changes. These changes cause weakening in the arterial wall, resulting in the aneurysmal dilatation. Then clinical effects. First is slow luminal narrowing causing ischemia and atrophy. Second is sudden luminal occlusion causing infarction, necrosis. Propagation of the plaque by formation of the thrombi and emboli. Then formation of the aneurysmal dilatation and eventual rupture. Large arteries affected most often are the aorta, renal, mesenteric and carotid, whereas the medium and the small sized arteries frequently involved are the coronaries, cerebrals, arteries of the lower limbs. Accordingly, the symptomatic atherosclerotic disease involves most often the heart, brain, kidney, small intestine and lower extremities. Then on heart, MI, ischemic heart disease, brain, chronic ischemic brain damage, cerebral infarction and stroke, aorta, aneurysm formation, thrombosis, embolization, small intestine, ischemic bowel disease and infarction, lower extremities, intermittent claudication and gangrene. And now comes the endarteritis obliterans. So we are starting with the blood vessel inflammatory disorders, right? So endarteritis obliterans. So endarteritis obliterans is not a disease entity but a pathological designation used for non-specific inflammatory response of the arteries and arterioles to a variety of irritants. So endarteritis obliterans is a non-specific inflammatory response to the arteries and arterioles of the arteries and arterioles to the irritant factors. or irritant substances, and it is commonly seen close to the lesions of the peptic ulcer of the stomach and duodenum, tuberculosis, and chronic abscesses in the lung, chronic cutaneous ulcers, chronic meningitis, postpartum and postmenopausal uterine arteries. Grossly, the affected vessel may appear unaltered externally, but no cross section show obliteration of their lumina. Microscopically, the obliteration of the lumina is due to the concentric and the symmetric proliferation of the cellular fibrous tissue in the intima. Though the condition has suffix, it is attached to it, and there is minimal or no inflammatory cell infiltrate. Right. And syphilitic aortitis. Syphilitic involvement of the ascending aorta and the aortic arch is the commonest manifestation of the cardiovascular syphilis, and it occurs in about 80% of the cases of the tertiary syphilis. Preferential involvement of the arc of aorta may be due to the involvement of the mediastinal lymph nodes in the secondary syphilis, through which the trypanosomes spread to the lymphatics around the aortic arc. The lesions diminish in the severity in descending thoracic aorta and disappear completely at the level of the diaphragm. Grossly, the affected part of the aorta may be dilated and its wall somewhat is thickened and adherent to the neighboring mediastinal structures. Longitudinally opened vessels show intimal surface stud with pearly white thickening varying from a few millimeters to a centimeter in a diameter. Then these lesions are separated by wrinkled normal intima, giving it characteristic tree bark appearance. Cut section of the lesion show more firm fibrous appearance than the Atheromatous plaque. However, superimposed atherosclerosis lesions may be present here. Microscopically, the conspicuous features are as under: endarteritis and periarteritis of the vasa vasorum located in the media and adventitia. Then perivascular accumulation of the plasma cells, lymphocytes, macrophages that may be miliary gammas which undergo necrosis and are replaced by a scar tissue. Intimal thickening consists of the dense avascular collagen that may undergo hyalinization and calcification. The effect of the syphilitic aortitis may vary from trivial to catastrophic. So these are as follows. First is aortic aneurysm, so may result from the damage to the aortic wall, and aortic valvular incompetence used to be considered an important sequela of the syphilis, but nowadays rheumatic disease is considered its more important cause, and the aortic incompetence results from the spread of the syphilitic process to the aortic valve ring. Then stenosis of the coronary ostia is seen in about 20% of the syphilitic aortitis and may lead to progressive myocardial fibrosis, angina pectoris, and sudden death. Then polyarteritis nodosa. So polyarteritis nodosa is a necrotizing vasculitis involving small and medium-sized muscular arteries of the multiple organs and tissues. Polyarteritis is the preferred nomenclature over the periarteritis because inflammatory involvement occurs in all the layers of the vessel wall, and the disease occurs more commonly in the adult male than in the females. Most commonly affected organs in descending order of the frequency of the involvement are the kidneys, heart, liver, gastrointestinal tract, muscle, pancreas, testes, nervous system, and skin. The syndrome of the PAN presents with the varied symptoms pertaining to different organs. However, some usual clinical features are fever, malaise, weakness, weight loss, renal manifestations, albuminuria, hematuria, renal failure, vascular lesions in the alimentary tract, abdominal pain, melena, and a peripheral neuritis and hypertension. And the condition is believed to result from the deposition of the immune complexes and the tumor related antigens. Then grossly, the lesions of the PAN involves the segments of the vessel, especially at the bifurcations and the branches, as Chinese beaded nodules. Microscopically, there are three sequential stages in the evolution of the lesions in the PAN. Acute stage, it is a fibrinoid necrosis in the center of the nodule located in the media. An acute inflammatory response develops around the focus of the fibrinoid necrosis. The inflammatory infiltrate is present in the entire circumference of the affected vessel, and it consists chiefly of the neutrophils and eosinophils and some mononuclear cells. The lumen may show thrombi, and the weakened wall may be the site of aneurysm formation. Healing stage, the characterized by marked fibroblastic proliferation producing firm nodularity, and the inflammatory infiltrate now consists mainly of lymphocytes, plasma cells and macrophages. Healed stage, in this stage the affected arterial wall is marked thickened due to the dense fibrosis, and the internal elastic lamina is fragmented or lost. Healed stage may contain hemosiderin-laden macrophages and organized thrombus. And however, it may be mentioned here that various stages of the disease may be seen in different vessels and even within the same vessel. Wegener's granulomatosis. Wegener's granulomatosis is one of the most important part of vasculitis. So Wegener's granulomatosis is another form of necrotizing vasculitis characterized by the clinico-pathological triad consisting of the following. First is acute necrotizing granuloma, focal necrotizing vasculitis, focal or diffuse necrotizing glomerulonephritis. So first is acute necrotizing granuloma of the upper and the lower respiratory tract involving the nose, sinuses and lungs. Focal necrotizing vasculitis, particularly of the lungs, upper airways, and focal or the diffuse necrotizing glomerulonephritis, a limited form of vaginal granulomatosis, is the same condition without renal involvement. As with PAN, the condition is more common in adult male and involves multiple organs and tissues. Most commonly involved organs are the lungs, paranasal sinuses, nasopharynx, kidneys, and other involved organs are joints, skin, eyes, ear, heart and nervous system. Accordingly, clinical features are variable. Typical features include pneumonitis with bilateral infiltrates in the lungs, chronic sinusitis, nasopharyngeal ulcerations and renal disease. The etiology is not known, but possibly the lesions occur due to the presence of circulating immune complexes, and this is supported by the observation of the subepithelial immunoglobulin deposits on the glomerular basement membrane and the induction of the remission of immunosuppressive therapy. The serum of these patients shows C and K positivity, and disseminated form of vaginal granulomatosis differs from the related entity idiopathic lethal midline granuloma in the sense that the latter condition is highly destructive and progressively necrotic disease of the upper airways. Histologically, the characteristic feature of vaginal granulomatosis is the presence of necrotizing granulomatous inflammation of the tissues and necrotizing vasculitis with or without granuloma. So the granuloma consists of the fibrinoid necrosis with the extensive infiltration of the neutrophils and mononuclear cells, epithelioid cells, multinucleate giant cells and fibroblastic proliferation. Then the necrotizing vasculitis may be segmental or circumferential, and the renal lesions are those of focal or diffuse necrotizing glomerulonephritis. Temporal arteritis. So this is another important vasculitis, and this is a form of granulomatous inflammation or of the medium sized and the large arteries. Preferential sites of the involvement are the cranial arteries, especially the temporal, and hence the name, right? However, the aorta and the major arteries like common carotid, axillary, brachial, femoral, mesenteric, they are also involved. Therefore, it is preferable to call it as a giant cell arteritis because these all are giant arteries. The patients are generally over the age of 70 years with slight female predispositions and preponderance मतलब कि slightly female में ज़्यादा होता है ये. And the usual clinical manifestations are headache and blindness if ophthalmic artery is involved. An association with polymyalgia rheumatica has been observed, and the cause of the condition remains unknown. Through there is suggestion of T cell mediated immunological reaction to some component of the arterial wall, especially against the damaged internal elastic lamina. Biopsy of the affected artery is not only the diagnostic value but also relieves the patient of the painful symptoms. Grossly, the affected artery is thickened, cord-like, and lumen is usually reduced to narrow slit. Histologically, the features include the following. First is there is chronic granulomatous reaction, usually around the internal elastic lamina, and typically involves the entire circumference of the vessel. Then the giant cell of the foreign body or Langerhans type are found in 2/3 of the cases. Then the internal elastic lamina is often fragmented. There is acentric and concentric intimal cellular proliferation causing marked narrowing of the lumen, and the narrowed lumen may contain thrombus. Then occasionally only the non-specific inflammatory cell infiltrate consisting of neutrophils, lymphocytes and eosinophils is found throughout the arterial wall. Then Takayasu arteritis, pulseless disease. So Takayasu arteritis is another important form of vasculitis. So this is a form of granulomatous vasculitis affecting chiefly the aorta and its major branches, and hence it is also called as aortic arch syndrome. And the disease affects chiefly young women, and it is typically characterized by the absence of the pulse in both arms and presence of the ocular manifestation. Other features referable to the ischemic effects of the thrombotic occlusion of the vessels include the MI and congestive heart failure and neurological deficits. Right? Wait a second. The etiology of the Takayasu arteritis is not known, but autoimmune reaction to the aortic tissue has been suggested as a possible cause. Grossly, the aortic wall is irregularly thickened and intima wrinkled. The branches of the major arteries coming off the aortic arc have been obliterated lumina. Histologically, there is severe mononuclear inflammatory infiltrate involving the full thickness of the affected vessel wall, and the inflammatory changes are more severe in the adventitia and the media, and there is perivascular infiltration of the vasa vasorum and granulomatous changes in the media with central necrosis and Langerhans giant cell are found in many cases, and advanced lesions show extensive fibrosis of the media and adventitia causing thickening of the vessel wall. Then Kawasaki disease. This is the other another important vasculitis. Wait a second. Yeah. Also known by more descriptive name mucocutaneous lymph node syndrome, or it is an acute and subacute illness affecting mainly young children and in fact infants. Kawasaki disease is a febrile illness with mucocutaneous symptoms like erosions of the oral mucosa, conjunctiva, skin rash, lymphadenopathy, and the etiology is unknown. Possible cause considered are infectious, genetic, toxic, and immunological. The most characteristic finding is the presence of the multiple aneurysm of the coronaries detected by angiography during life and observed at autopsy. Other vessels that may be involved are renal, mesenteric, hepatic, and pancreatic arteries. Histologically, the picture of the panarteritis resembling the PAN, characterized by the necrosis, inflammation of the entire thickness of the vessel wall. Therefore, some consider Kawasaki disease as an infantile form of PAN. Right? And Burger's disease, thromboangiitis obliterans, this is also an important topic. So Burger's disease is a specific disease entity affecting chiefly small and medium sized arteries and veins of the commonly lower extremities, and it is having a risk factor of smoking or basically etiology, right? So, and characterized by the acute and chronic occlusive inflammatory involvement. The disease affects chiefly men under the age complex consists of the intermittent claudication due to the ischemia, manifested by intense pain affecting the limbs and more commonly in the legs. Eventually, gangrene of the affected extremity occurs, requiring the amputation of the area. And etiopathogenesis, so following possible mechanisms have been suggested. First is there is consistent association with heavy cigarette smoking, and this has led to the hypothesis that tobacco products cause either direct endothelial damage or they lead to hypercoagulability and thrombosis, or it is a result in hypersensitivity to tobacco products. And in support is the demonstration of anti-endothelial cell antibodies, AECAs. And second is genetic factors. Genetic factors play a role as the disease has familial occurrence and has a HLA association. An increased prevalence is seen in the individual with HLA-A9 and HLA-B5 antigens, and it is seen more commonly in the persons from Israel, Japan, and in India. Grossly, the lesions are typically segmental, affecting the small and medium-sized arteries, especially of the lower extremities, and involvement of the arteries is often accompanied with the involvement of the adjacent veins and nerves. And fibrous tissue cuff generally surrounds these three structures. And then mural thrombi are frequently present in the vessels. Microscopically, the following changes are seen in the different stages of the disease. First is, in early stage there is infiltration of polymorphs in all the layer of the vessels, and there is invariably presence of the mural or occlusive thrombosis of the lumen, and the presence and the appearance differs from the atherosclerosis in having the microabscesses in the thrombi and proliferation of the endothelial cells, lack the lipid aggregates, and presents the intact internal elastic lamina. In advanced stage, the cellular infiltrate is predominantly mononuclear and may contain an occasional epithelioid cell granuloma with Langerhans giant cell. And the thrombi undergo organization and recanalization, and in more chronic cases, marked fibrosis of the media is also present. Then Raynaud's disease, Raynaud's phenomena. So Raynaud's disease is not a vasculitis, but it is a vasospastic disorder, जहाँ पर आपकी आर्टरीज जो हैं दे बिकम साइको, और कहीं से ऐसे कॉन्ट्रैक्ट करेगी, कहीं से डायलेट करेगी, एंड thus it will be causing a vasospastic disorder, right? So Raynaud's disease and the Raynaud's phenomenon. So Raynaud's disease is not a vasculitis, but it is a functional vasospastic disorder affecting chiefly small arteries and arterioles of the extremities. Occurring in otherwise young healthy females, the disease affecting the most commonly fingers and hands. The ischemic effect is provoked primarily by cold, but other stimuli such as emotion, trauma, hormone, and drug also play a role. Clinically, the affected digits show pallor followed by cyanosis and then redness corresponding to the arterial ischemia, venostasis, hyperemia respectively. Long-standing cases may develop ulceration and necrosis of the digits, but occurrence of the true gangrene is rare. The cause of the disease is unknown but probably occurs due to the vasoconstriction mediated by autonomic stimulation of the affected vessels. Though usually no pathologic changes are observed in the affected vessels, and long-standing cases may show endothelial proliferation and intimal thickening. Then Raynaud's phenomena. Raynaud's phenomena differs from the Raynaud's disease in having the underlying cause, example secondary to the atherosclerosis, or connective tissue disorders like scleroderma, SLE, Buerger's disease, multiple myeloma, pulmonary hypertension, ingestion of the ergot group of the drugs in migraine or any other disorders. So Raynaud's phenomena like Raynaud's disease also show cold sensitivity, but differs from the latter in having a structural abnormality in the affected vessel. These changes include the segmental inflammation, fibrinoid change in the walls of the capillaries. अब बात करते हैं एन्यूरिज्म की. An aneurysm is defined as permanent abnormal dilatation of the blood vessel occurring due to the congenital or acquired weakening or destruction of the vessel wall. Most commonly, aneurysm involve large elastic arteries, especially the aorta and its branches. Aneurysm may cause various ill effects such as thrombosis, thromboembolism, alteration in the flow of the blood, rupture of the vessels, compression of the neighboring structures. Aneurysm can be classified on the basis of various features. First is depending upon the composition of the wall. First is true aneurysm and second is false aneurysm. True aneurysm composed of all the layers of the normal vessel wall, but a false aneurysm is having the fibrous wall only and occurring often after a trauma. Then B, depending upon the shape, these are as under. First is saccular, second is fusiform, third is cylindrical, fourth is serpentine, and fifth is racemose. And C, based on the pathogenetic mechanisms, first is atherosclerotic aneurysm, this is the most common type. Syphilitic aneurysm, that is found in tertiary stage of syphilis. Dissecting aneurysm, dissecting hematoma, in which blood enters the separated and dissected wall of the vessel. Mycotic aneurysm, weakening of the arterial wall by microbial infection. Berry aneurysm, which are small dilatation, especially affecting the circle of Willis in the base of brain, and that generally causes hemorrhages, right? Berry aneurysm. Then atherosclerotic aneurysm. Atherosclerotic aneurysm are the most common form of the aortic aneurysm, and they are seen more commonly in the males and are frequently increases after the age of 50 years when the incidence of the complicated lesions of advanced atherosclerosis is higher. They are the most common in the abdominal aorta, so much so that all forms of aneurysm of abdominal aorta, fusiform, cylindrical, saccular, should be considered atherosclerotic until proved otherwise. Other locations include thoracic aorta, iliac arteries, and other large systemic arteries. Then pathogenesis. Obviously, severe atherosclerotic lesions are the basic problem which cause thinning and destruction of the medial elastic tissue, resulting in the atrophy and weakening of the wall. And since the atherosclerotic lesions are the most common and the severe in abdominal aorta, atherosclerotic aneurysm occur most frequently here. And in the thoracic aorta, besides the atherosclerotic lesion, medial degeneration is another additional factor implicated in pathogenesis. Now morphological features. Morphological features. Atherosclerotic aneurysm of the abdominal aorta are most frequently infrarenal, above the bifurcation of the aorta, but may extend into the common iliac arteries. They may be of variable size, but are often larger than 5 to 6 centimeters in the diameter. Atherosclerotic aneurysm is most frequently fusiform in shape, and the lumen of aneurysm often contains mural thrombus. Histologically, the wall of the atherosclerotic aneurysm loses its normal arterial structure. Instead, there is predominance of the fibrous tissue in the media and adventitia with mild chronic inflammatory reaction. The intima and the inner part of the media show remnants of the Atheromatous plaque and mural thrombus. Then effects. First is rupture. Rupture of the atherosclerotic aneurysm is the most serious and the fatal complication. The risk of the rupture depends upon the size and the duration of the aneurysm and the BP. Rupture of the abdominal aneurysm may occur either in the peritoneum or into the retroperitoneal, resulting into the sudden and the massive bleeding. Occasionally, there may be slow progressive leak from the aneurysm. A ruptured aneurysm is more likely to get infected. Then compression. The atherosclerotic aneurysm may press upon the adjacent structures such as compression of the ureter, erosion of the vertebral bodies. Then third, arterial occlusion. Atherosclerotic aneurysm of the abdominal aorta may occlude the inferior mesenteric artery and there may be the development of the occlusive thrombosis. However, collateral circulation develops slowly and is nearly available sufficient so as not to produce any effects of ischemia. Thromboembolism is rather common in abdominal aneurysm. And dissecting aneurysm and cystic medial necrosis. The term dissecting aneurysm is applied for the dissecting hematoma in which the blood enters the separated wall. So guys, this is the normal lumen of the wall, ठीक है. Then now what happens कि थोड़ा सा ऐसे कट सा लग गया and this is the and this becomes the false lumen and blood gets filled into this, right? And this is the dissected or separated wall of the vessel, right? And then blood start filling here and longitudinally, right? And the most common site is aorta and it is an acute catastrophic aortic disease, and the condition occurs most commonly in men in the age range of 50 to 70 years of age, and in women dissecting aneurysm may occur during pregnancy. Then pathogenesis. The pathogenesis of the dissecting aneurysm is explained on the basis of weakened aortic media because this failed in media. And hypertensive state. About 90% cases of the dissecting aneurysm have hypertension, which predisposes such patient to degeneration of the media in some questionable way. Then in non-hypertensive states. Non-hypertensive states के अंदर these are the cases in whom there are some local and systemic connective tissue disorders. Example, Marfan syndrome, autosomal dominant disease with genetic defect in fibrillin, which is a connective tissue protein required for elastic tissue formation. Then B, development of the cystic medial necrosis of erythema, especially in old age, iatrogenic trauma during cardiac catheterization and coronary bypass surgery. Then pregnancy for some unknown reasons. Once medial necrosis has occurred, then hemodynamic factors and chiefly hypertension cause tear in the intima and initiate the dissecting aneurysm. Then media is split at its weakest point by the inflowing blood, and alternative suggestion is that the medial hemorrhage from the vasa vasorum occurs first and then intimal tear follows it. Further extension of the aneurysm occurs due to the entry of the blood into the media through the intimal tear. So, right, and what is this? Further extension of the Then morphological features. So dissecting aneurysm differs from the atherosclerotic and syphilitic aneurysm and is having no significant dilatation. Therefore, it is currently referred as dissecting hematoma. Hematoma is a kind of area जहाँ पर काफी सारा blood accumulate हो जाता है. So rather than aneurysm, it is often referred as hematoma because this is the abnormal site where blood gets accumulated. This is the normal vessel, but from normal vessel it gets accumulated to the media, and thus it is also called as hematoma. Then dissecting aneurysm classically begins in the arc of aorta, and in 95% of the cases there is a sharply incised transverse and oblique intimal tear 3 to 4 centimeter long and most often located in the ascending part of the aorta, and the dissection is seen most characteristically between the outer and the middle third of the aortic media, so that the column of the blood in the dissection separates the intima and the inner 2/3 of the media on one side from the outer 1/3 of the media and the adventitia on the other side, and the dissection extend proximally into the aortic valve ring as well as distally into the abdominal aorta. Occasionally The dissection may extend into the branches of aorta, example into the arteries of the neck, coronaries, renal, mesenteric and iliac arteries. The dissection may affect the entire circumference of the aortic media or a segment of it. In about 10% of dissecting aneurysm, a second intimal tear is seen in the distal part of the dissection, so that blood enters a false lumen through a proximal tear and re-enters the true lumen after a distal tear. So ये कुछ ऐसी सी सिचुएशन हो जाती है कि blood from the proximal tear it comes into a false lumen, and then it does a distal tear, जिसकी वजह से it again come to the main true lumen, right? And if the patient survives, the false lumen may develop endothelial lining and double barrel aorta is formed. मतलब ये भी pathway on हो जाता है, ये भी pathway on हो जाता है, and double barrel pathway is formed, right? And two classification schemes of dissections of the thoracic aorta and intramural hematoma have been described. First is D-Begay classification. D-Begay classification में type 1, type 2, type 3. Type 1 comprises of the 75% of the cases and the intimal tear begins in the ascending aorta, but dissection ascends distally for some distance. Type 2 के अंदर it comprises 5% of the cases and dissection is limited to the ascending aorta only. Type 3 के अंदर institutes the remaining 20% of the cases, and in these cases intimal tear begins at the descending aorta near the origin of the subclavian artery and dissection extends distally. And second is Stanford classification. So he has divided it into two types. First is type A. Type A के अंदर proximal dissection involves the ascending aorta and includes the type 1 and type 2 of D-Begay classification. Then type B, that is distal dissection, and it is limited to the descending aorta and sparing the ascending aorta, and it is the type 3 of the D-Begay classification. Then third is histologically. The characteristic feature of cystic medial necrosis are found, and these are as under: focal separation of the fibromuscular and elastic tissue of the media. Second, numerous cystic spaces in the media containing basophilic ground substance. Third, fragmentation of the elastic tissue. Fourth, increased fibrosis of the media. Then effects. The classical clinical manifestation of a dissecting aneurysm is excruciating tearing pain in the chest moving downward, and the complication arises from the dissecting aneurysm are as under. First is rupture, second is cardiac disease, and third is ischemia. Rupture. Hemorrhage from rupture of the dissecting aneurysm is the ascending aorta results in mortality in 90% of the cases. Most often hemorrhage occurs into the pericardium, and less frequently it may rupture into the thoracic cavity, abdominal cavity or retroperitoneum. Then cardiac disease. Involvement of the aortic valve results in the aortic incompetence and obstruction of the coronaries, resulting into ischemia, causing fatal MI. Rarely dissecting aneurysm may extend into the cardiac chamber, right? So it is a rare situation. Ischemia. Obstruction of the branches of aorta by dissection results in ischemia of the tissue supplied. Thus, there may be renal infarction, cerebral ischemia, infarction of the spinal cord. Then varicose veins. Varicose veins are permanently dilated and tortuous, superficial veins of the lower extremities, then especially the long saphenous vein and its tributaries. About 10 to 12% of the general population develops varicose veins of the lower legs, with the peak incidence in 4th and the 5th decades of life. Adult females are affected more commonly than in the males, especially during pregnancy. This is attributed to venous chases in the lower legs because of the compression of the iliac veins by the pregnant uterus. And then etiopathogenesis, a number of etiologic and pathogenic factors are involved in causing the varicose veins, and these are as follows. uh, Wait a second. um, yeah, everything is fine. Yeah, yeah. What's yes, etiopathogenesis. First is familial weakness of vein wall and valves is the most common cause, and second is increased intraluminal pressure due to the prolonged upright posture, example in nurse, policemen, surgeons. Third, compression of iliac veins during pregnancy, intravascular thrombosis, growing tumor. Fourth, hormonal effects of the smooth muscles. Fifth, obesity, and sixth, chronic constipation. So these are the few factors that leads to varicose veins. So morphological features. The affected veins, especially of the lower extremities, are dilated, tortuous, elongated, and nodular. Right. Intraluminal thrombosis and vascular deformities are often found, and histologically there are variable fibromuscular thickening of the wall of the veins due to the alternate dilatation and hypertrophy. Degeneration of the medial elastic tissue may occur, which may be followed by calcific foci. Mural thrombosis is commonly present, which may get organized and hyalinized, leading to irregular intimal thickening. Effects. Varicose veins of the legs result into venous stasis, which is followed by congestion, edema, thrombosis, stasis, dermatitis, cellulitis, ulceration, and secondary infection results into the chronic varicose ulcers. And then phlebothrombosis or thrombophlebitis. The term phlebothrombosis or thrombus formation in the veins and thrombophlebitis, that is inflammatory changes within the vein wall, are currently used synonymously. And etiopathogenesis क्या है इसका? Venous thrombosis that precedes the thrombophlebitis is initiated by the triad of changes. First is endothelial damage होता है, then alteration in the composition of the blood, then venous stasis, and the factor that predispose to these conditions are cardiac failure, malignancy, and use of estrogen containing compounds, post-operative state, immobility due to the various reasons. Then morphological features. The most common locations of the phlebothrombosis and thrombophlebitis are deep veins of legs, accounting for more than 90% of the cases, and thus it is termed as deep vein thrombosis. Other locations are periprostatic venous plexus in male and pelvic veins in the female, and near the foci of infection in the abdominal cavity, such as acute appendicitis, peritonitis, acute salpingitis, and pelvic abscesses. Then grossly, the affected veins may appear normal or may be distended and firm. Often a mural or occlusive thrombus is present. Then histologically, the thrombus that is attached to the vein wall induces inflammatory reparative response beginning from the intima and infiltrating into the thrombi. And the response consists of the mononuclear inflammatory cells and fibroblastic proliferation. And in the late stage, thrombus is either organized, resolved, leading to thick-walled fibrous vein. Then effects. The clinical effects due to the phlebothrombosis or thrombophlebitis may be local or systemic. Local effects are edema distal to occlusion, heat, swelling, tenderness, pain, redness. And systemic effects are more severe because embolic phenomena, pulmonary thromboembolism, these are being most common and most important and most dangerous. And other systemic manifestations include bacteremia, septic embolism to the brain, meninges, and liver. Right. Now comes the most important topic and the last topic of today's session, that is Kaposi sarcoma. Right, so this is the last topic of the today's session. Today's मतलब कि blood vessel disorders का last topic है ये. Kaposi sarcoma is a malignant angiomatous tumor. Malignant angiomatous tumor first described by Kaposi. So इसका नाम पड़ गया Kaposi sarcoma. Hungarian dermatologist. However, the tumor has attracted greater attention in last two decades due to the frequent occurrences in the patient with HIV and AIDS. So classification: presently 4 forms of Kaposi sarcoma are described. First is classical, second is African, third is endemic, and fourth is renal transplant cases में. So first is classical Kaposi sarcoma. This is the form which was described by Kaposi, and it is the most common in men over 60 years of age of Eastern European descent. The disease is slow growing and appears as multiple small purple dome-shaped nodules and plaques in the skin, especially on the legs. Involvement of the visceral organs occurs in about 10% of the cases after many years. Then African endemic Kaposi sarcoma. So this form is common in equatorial Africa. So it is also common in Uganda. That comprises 9% of all the malignant tumors in men. So it comprises 9% of all the malignant tumors in men, and it is found in younger age. So that was in older age, and this is in the younger age, especially in the boys and young men, and has more aggressive course than the classical form. And the disease begins in the skin but grows rapidly to involve other tissues, especially the lymph nodes and the gut. Then epidemic AIDS associated Kaposi sarcoma. This form is seen in about 30% of the cases of AIDS, especially in the young male homosexuals and the other high risk groups. The cutaneous lesions are not localized to lower legs but are more extensively distributed, involving the mucous membranes, lymph node, internal organs early in the course of disease, right? So early ही lymph nodes affect हो जाते हैं, membranes, internal organs सब affect हो जाते हैं. That's why prognosis is bad. And Kaposi sarcoma in renal transplant cases. This is the form associated with the recipient of the renal transplant who have been administered immunosuppressive therapy for a long time, and the lesions may be localized to the skin or may have widespread systemic involvement. Then pathogenesis. Pathogenesis of the Kaposi sarcoma is complex. It is an opportunistic neoplasm. So this is a opportunistic neoplasm. Keyword देख रहे हो? Opportunistic neoplasm in the immunosuppressed patients, obviously, which has excessive proliferation of the spindle cells of the vascular origin, having features of both endothelium and smooth muscle cells. So एक special type के spindle cells produce होते हैं that is having the features of both endothelium plus smooth muscle cells. Then epidemiological studies have suggested a viral association implicating HIV and human herpes 8 (HSV8), also called as Kaposi sarcoma associated herpes virus (KSHV). And second occurrence of the Kaposi sarcoma involves interplay of HIV-1 infection, HHV8 infection, and activation of the immune system and secretion of the cytokinins. Higher incidence of Kaposi sarcoma in male homosexual is explained by increased secretion of cytokinins by their activated immune system. Then defective immunoregulation plays a role in its pathogenesis and is further substantiated by observation of the second malignancy, that is leukemia, lymphoma and myeloma. And in about 1/3 of the patient with Kaposi sarcoma, this is common. And morphological features. Pathologically, all forms of the Kaposi sarcoma are similar. Grossly, the lesions in the skin, gut, other organs are prominent, irregular, purple, dome-shaped, plaques, nodules. Histologically, the changes are non-specific in the early patch stage and more characteristic in the late nodular stage. And the early patch stage, there is irregular vascular spaces separated by interstitial inflammatory cells and extravasated blood and hemosiderin. Late nodular stage के अंदर there are slit-like vascular spaces containing red blood cells and separated by spindle-shaped plump tumor cells, and these spindle-shaped tumor cells are probably of endothelial origin. And the clinical course and the biological behavior of Kaposi sarcoma is quite variable. The classical form of Kaposi sarcoma is largely confined to the skin, and the course is generally slow and insidious with the long survival. and the endemic, that is African, and epidemic, that is AIDS associated Kaposi sarcoma, on the other hand, has a rapidly progressive course and often widespread cutaneous as well as visceral involvement and high mortality and poor prognosis. So that was all for today's session, and फटाफट से एक बार देख लेते हैं कि हमने क्या क्या पढ़ा, एंड देन वी विल एंड दिस सेशन. सो फर्स्ट ऑफ ऑल हमने पढ़ा आर्टियोस्क्लेरोसिस. सबसे पहले तो हमने थोड़ा फिजियोलॉजी पॉइंट ऑफ व्यू देखा, फिर हमने आर्टियोस्क्लेरोसिस पढ़ा, सिनाइल आर्टियोस्क्लेरोसिस, हाइपरटेंसिव आर्टियोस्क्लेरोसिस. देन हमने देखा मॉन्कीबर्ग्स आर्टियोस्क्लेरोसिस, मीडियल कैल्सिफिक स्क्लेरोसिस, एथेरोस्क्लेरोसिस एंड रिस्क फैक्टर etiology and all, right? Then we have studied the full question पढ़ा हमने इसका. देन सिफिलिटिक, देन हमने वैस्कुलाइटिस स्टार्ट करा और ब्लड वेसल्स की इन्फ्लेमेशन स्टार्ट करी. एंडार्टराइटिस, ओब्लिटरेंस, सिफिलिटिक आर्टाइटिस, पॉलीआर्टराइटिस नोडोसा, देन वेगनर्स और वेजनर्स ग्रैनुलोमेटोसिस, देन टेम्पोरल आर्टराइटिस और जाइंट सेल, टाकायासु आर्टराइटिस, कावासाकी डिजीज, बर्गर्स डिजीज, देन रिनॉल्ड्स डिजीज, एंड देन एनोरिज्म थोड़ा सा देखा, एंड डाइसेक्टिंग एनोरिज्म देखा, एंड उसके इफेक्ट्स, वेरिकोज वेन्स भी डिस्कस करा, थ्रोम्बोफ्लेबाइटिस भी डिस्कस करा, कापोसी सार्कोमा भी डिस्कस कर लिया. एंड विद दिस वी हैव कंप्लीटेड द veins, blood vessel and its disorder wala part. Now in the next session we will be doing the heart, and I will be seeing you there at 4 p.m. Yeah, thank you so much for coming. And yeah, अगर आपको स्पेशल क्लास लेनी है then you have to use code Virmani. It is free but code use करना पड़ेगा. एंड कोड क्या यूज़ करोगे? विरमानी. एंड yeah, bye guys, take care, stay healthy, stay positive, stay safe and keep fighting for your goals, and take care. Bye guys.